Today is the first day of KSOS PG classroom, which is mainly intended for postgraduate students to help them prepare for their exams. So this will be based on case presentations on every topic in ophthalmology, which is usually asked as long and short cases for your exam. So this cases will be presented by one of the postgraduates from one of the medical colleges in Kerala. And the discussion will be done by one of the expert faculty and an examiner. So this will be done once in 2 weeks. And today, being in the middle of the glaucoma week, we will be starting with the glaucoma case, which would be presented by Amrita Institute of Medical Sciences. The presenter would be Dr. Shubhanetra, and the expert faculty will be Dr. Manoj Pradhaban, who is the consultant in glaucoma in Amrita, and also examiner will be Dr. Gopalas Pillai. So over to you, Dr. Netra. Shall we start the presentation?
Yes. Just wait for Dr. Gopalas Pillai.
Yes.
Netra, you can start your slide share.
Yes, sir.
Sir is here.
I'll start, sir.
Yeah, you can start.
Good evening, everyone. Today I'm presenting a case of a 70-year-old homemaker who presented to us with redness and pain in both the eyes for 3 years and loss of vision in the right eye for 2 years and decrease of vision in the left eye for a period of 1 year. History of presenting illness: 70-year-old lady with no known comorbidities presented with complaints of pain in both the eyes, which started 1 month apart, first in the right eye, followed by the left eye, 3 years back. She gives us a history of pain, mostly in the frontal region, which worsened on watching TV and reading newspaper. It was associated with redness and photophobia in both the eyes. No history of colored halos. 2.5 years back, she instantly noticed loss of vision in the right eye. And 1 year back, she noticed decrease of vision in the left eye, which was gradually progressive, such that she found it difficult to identify people's faces. She developed severe pain with redness in both the eyes 1 year back, for which she consulted elsewhere, and laser peripheral iridotomy was done in both the eyes. Past medical, surgical, and drug history: YAC peripheral iridotomy was done in both the eyes elsewhere 1 year back, and she was instilling in both the eyes since then. Predestate eye drops 1% BD, dorzolamide 2%, timolol eye drops 0.5% BD, bromelain eye drops 0.2% BD. She gives us no history of joint pain or deformities, no weight loss, no chronic cough, no history of evening rise of temperature. And general examination.
Netra, from here, can you give us a few differential diagnoses for such a presentation?
As the patient was complaining of redness and pain for a long duration, it could be because the patient has uveitis or because of prolonged history of dry eyes, or it can be because of history of glaucoma, because there's a decrease of vision in a significant decrease of vision in the right eye and progressive decrease of vision in the left eye.
Okay, so what are the pertinent positive findings in the history? Can you tell once again for everybody?
First, redness and pain in both the eyes for 3 years, loss of vision in the right eye for 2 years, and decrease in vision in the left eye, which was gradually progressive over 1 year.
Okay, so the redness and pain was off and on as episodic?
Yes, sir. It was continuous, sir. It was not episodic, it was continuous. It was not, there was no intermittent breaks, anything. It was continuously there.
Okay.
How severe was the pain?
The pains, initially it was not very significant, a very severe pain. So only when after 1 year back was when her pain was very significant, that she couldn't, that's when she had gone to the hospital and she had got a PET laser PI transfer.
There was an episode of a severe pain about 1 year back.
Yes, sir.
But before that, it was a bearable pain.
Bearable pain, sir. Yes, sir.
Okay, and when there was a severe pain, that is a point of time when she got the YAC PI done, is it?
Yes, sir.
So before starting with decreased vision, she had redness and pain, and then she had decreased vision in both eyes. Was there any photophobia?
Yes, sir. She had photophobia, sir.
Okay.
What is photophobia? Meera? What is photophobia?
So the patient will have difficulty in looking at the light, sir.
No.
Difficulty in looking at the light.
Yes.
Sir, in ambient lighting, when the patient is having a difficulty in looking, like in the surrounding, or having complaints of pain, is what is called as photophobia. The keyword is being ambient lighting.
Pain on exposure to ambient light. Pain on exposure to ambient
Yes,
light
sir.
is photophobia.
Yes.
So what is the cause of photophobia? Yes.
Sir, it can point towards uveitis, because uveitic, basically iris, the movement of iris due to the changing ambient light is causing the pain. So iritis can be one of the cause, anterior uveitis, iritis.
So basically, pupillary reflex is the reason for the photophobia.
Yes, sir.
So you
Yes,
give,
sir, yes.
okay. So what will be the treatment for such a pain? Is it like paracetamol or NSAIDs or something
No.
else?
No, sir. In this case, since there is iritis, that is inflammation of the iris, as well as since the movement is also causing the pain, we can give a mediatic in order to stop the movement of the iris, as well as to control the inflammation. We'll give steroids.
Okay. And for the cyclospasm, we will give it also have
Yes, sir.
cycloplegic action. Okay.
Yes.
So any other condition where photophobia can be seen other than just anterior uveitis?
In migration,
Corneal ulceration.
Corneal ulcerations, epithelial defect.
Basically, corneal ulcer
Recurrent.
also, it is basically the uveitis that is coming along with that. Causes the, so you give for ulcer also, you can give cycloplegics to relieve photophobia. Okay. Can this be cataract, Nedra? Very common cause of decrease in vision. Can this be cataract?
It could also be cataract that the patient has ignored the symptoms and suddenly she's realized that she's been ignorant about her symptoms, and then she's noticed that she's had a decrease of vision, but that could not be redness and pain because of the cataract, sir.
Can cataract cause redness and pain in any stage?
Intumescent cataract can cause redness and pain if it is causing a glaucoma, sir. In causing
Okay,
a
what is that called?
phacomorphic
Okay.
glaucoma.
Is there any other cause for such inflammation in cataract? Unmute. Yes.
Phacolytic glaucoma.
Yeah, phacolytic. So all these are in hypermature stage. The patient of first notice decreased vision, then pain would have started. So in this case, but actually the patient started noticing pain and redness, and then patient developed decrease in vision. Okay. Any other
Okay, so
possibilities?
in your differential diagnosis of uveitis or some angle closure glaucoma or dry eye, you said angle closure glaucoma also has a possibility from history? Yeah. So what goes against uveitis in this case? I'm talking only about history, all right? What goes against uveitis? Gargi?
The decrease.
What goes against uveitis? You can unmute.
So decrease of vision.
So basically, the age group of the patient. Age group of the patient is such that uveitis is not something that will be coming first in the mind.
Okay. Anil, your video, you can on your video, please.
Yeah. Gopal, can I join?
Please,
There
please,
people
please,
from-
please, please,
Yeah,
please,
yeah.
please,
Okay.
please, please.
So is that based on the history? I think we are looking at two possibilities. One is uveitis and other is the angle closure glaucoma. Anything else that you can think of? Netra.
Recurrent corneal erosions.
Recurrent corneal erosion. No, but that gives a classical history. No, the patient wakes up usually in the morning with foreign body sensation, redness, and severe watering. And every day it happens in a regular, I mean, not in a regular frequency, but it happens quite often. And pain on waking up is characteristic of recurrent erosion. Anything else? Something more common that we see in the cornea? I think there are parallels with uveitis, but HSV keratitis can also come like this. Multiple episodes of pain, redness, and sometimes it may be epithelial keratitis, sometimes it may be HSV stromal keratitis, in which case there will be decrease in vision also. Epithelial keratitis, it may cause some decrease in vision, but not too much, generally. Okay, fine.
Okay, so let's go to the examination. Anything else, Manoj or Rehana? Anything? Okay, let us just go to examination, please.
On general examination, patient was moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Vitals, pulse rate was 72 per minute. BP was 110/82 millimeter of mercury, and temperature was 98.3 degree Fahrenheit. In ocular examination, both eyes' ocular alignment was orthotropic. Extraocular movements were full and equal in both the eyes. Visual acuity, the right eye for distance was perception of light was present, while perception of rays was inaccurate, and in the left eye was 6/60, not improving with pinhole, and near vision was N36.
What does it mean to have a vision of PR inaccurate? What does it point to?
Optic atrophy.
What do you mean? PR inaccurate vision, what does it indicate?
Atrophy due to any process.
Didn't get that. Can you tell me once again? Did not get that.
Optic atrophy, sir.
Yes.
Okay. So you mean to say that there is a retinal detachment of the temporal quadrant? Okay. Will the PR be inaccurate?
No.
No. Okay. In a retinal detachment, if the PR is inaccurate, what does that signify?
Consecutive optic atrophy. Long-standing retinal.
Very good.
Yes.
So in a case of retinal detachment, if there is a PR inaccurate, then you should think that optic nerve is damaged because the retinal detachment had been very, very long standing. In a cataract, will there be PR inaccurate?
No. Unless optic
Dense
atrophy.
cataract. Dense cataract? No? Okay.
No.
Okay. No amount of media opacity should be causing a PR inaccurate. Okay. But can you tell me some complications or sequelae of lens, cataract, which can actually cause PR inaccurate?
As in phacomorphic glaucoma causing optic atrophy?
Yes.
Yes.
Phacomorphic. Not just optic atrophy, even functional optic nerve damage can occur with very high pressures.
Yes.
Okay. So very high pressures can actually cause PR inaccurate. All right.
Yes.
What else? So one is phacomorphic.
Intumescent lens.
Equilitic.
Decreased IUP causing decreased perfusion, causing an optic atrophy.
So what is the diagnosis, Netra?
Very good. Sir?
What is the diagnosis of what you're saying?
Acute angle.
acute angle closure glaucoma.
Yes, sir.
Okay, if the IOP is very, very high, like plecomorphic glaucoma, you can have. So other eye was having 6/60 vision. What about the NIP? What does it mean to have a NIP vision?
There is on using a pinhole, it doesn't improve because of the macula. There's a problem with involving the macula.
Is it only macular diseases which can have NIP vision, or any other conditions which can also have NIP vision?
Posterior
Even-
subocular cataract can
But
have.
also, yeah, any opacities in the line of the rays can also cause.
So like cataract and
Corneal scarring.
okay, focal opacity, or what else is there in the media? Cornea, lens, what else is in the media?
Vitreous.
So
It is
it is hemorrhage, no? Okay. Or macula, generally macula pathologist, or optic atrophy. If it is
What is the
refractive,
size of
it
the
should
macula
improve.
hole? What is the size of the pinhole? Sorry. What is the size of the hole?
0.2 mm.
point.
Point?
2 mm.
No.
Sir, 1 mm.
It's about 0.9 mm.
So what does it do? Why does a 0.1 mm opening in the eye cause an improvement in vision in refractive errors? What is the reason?
Cuts off the peripheral rays so that the light will fall onto the center of the, focuses on the macula.
Anybody else?
Sir, it nullifies the refractive errors because only concentrated light rays passing through the lens, and thereby lessening the chance of any aberrations or other
Anybody else?
refraction.
The light that passes through the principal axis do not undergo refraction. It just passes straight through without refraction. So that is the principle that we are using. So cutting off the peripheral rays, the light that is going central through the optical system goes straight through without refraction. Okay. So we can go to the next slide.
Intraocular pressure by Goldman's application tonometer at 10 a.m. in the right eye was 56 millimeter of mercury and the left eye was 40 millimeters of mercury. An anterior segment examination. In the right eye, cornea was clear. There was
Excuse me, Netra. Before that, we will talk about the lid position, conjunctiva, before you go to the cornea.
Okay, sir.
Because you are seeing there was red eye. So I'm interested to know if there is red eyes.
Eyelids were normal. Eyelids and eyelashes were normal. Conjunctiva, there's no congestion, discharge, or chemosis. Cornea was
So there
clear.
is no congestion.
No congestion.
Patient presented with redness for 3 years. There is no congestion right now.
But then when we saw the patient, there was no congestion. Sir.
Okay.
Patient
What
was
kind of
already
congestion
using
do you expect in a
steroids.
patient with your differential diagnosis of uveitis? What did you normally expect? What type of congestion? Circumciliary congestion. Okay. Why is it seen only in around the cornea? Corneal congestion. Why is it around the cornea alone? Why not say in the corneas?
Because of there's a decrease in the uveal blood flow.
Lisa?
Sir, because of the ischemia causing there is a decrease in the uveal blood flow.
Ischemia. Why would there be ischemia in uveitis?
Sir, inflammation of ciliary body.
Inflammation.
Inflammation of the ciliary body will cause.
So inflammation will cause dilatation of blood vessels, no? So these
Yes.
circumcorneal vessels are originating from the ciliary circulation.
Yes.
So in inflammatory pathology of the uvea, you will have circumcorneal congestion. So how will you differentiate it with the diffuse congestion? What are the methods to differentiate a circumcorneal congestion from a diffuse congestion?
Sir, vasopressin, we can use vasoconstrictors like phenylephrine. So circumciliary congestion will not blanch, and the other conjunctival congestion would be blanching. Then bright red vessels will be seen more in the circumciliary congestion.
Bright red will be in the superficial congestion.
Superficial congestion and
Violaceous in
Yeah.
when movable vessels will be seen in the superficial congestion, the vessels will be not that immobile in the case of circumciliary congestion.
And you can trace the origin of the blood vessels towards the fornix in diffuse congestion. Okay. So after conjunctiva, what comes? Nathan?
Yeah, before we go, I mean, yeah, I think we missed about this position of the eye. No, you didn't make a comment about the position of the eye. It's very important in this particular case because
that was already told in the previous slide.
Already mentioned. Okay,
yes,
okay, fine.
Photophobia was already told. Extraocular movements normal also was told.
Okay, fine.
Yeah.
But what would you expect if in a 65, 70-year-old person, if there is a loss of vision in one eye suddenly, would you expect some position abnormality of the eye? Will it be esotropia or exotropia?
Exotropia, long-standing, then it can be exotropia.
Why is there exotropia, Nitro?
Extra.
Yes, Lisa, Amrita.
Since there is a sensory cutoff to the eye is not able to see or visualize outer environment. So the eye will go into the position of least.
It's breaking of fusion, no? So you lose sensory supply, so the fusion is lost. So phoreas get converted into tropias. Yeah. Sometimes the unilateral cataract can present with a exophoria, a dense cataract. And that tropia may disappear after cataract surgery. Okay, so here it is a blind eye, one eye. So that we expect that some amount of exophoria in normal cases, most cases. All right.
Again, you should understand that sensory deprivation in a very young age, like less than 1 year of age, can cause exotropia. 1 to 9 years can cause esotropia. And then later on in adult life, it can cause exotropia because that is a position of rest. Okay, yeah. Let's move on. Anil, any other question that you want to ask?
Nothing, Gopal, at this point of time.
Let's go to the next part of the examination. Netra.
Cornea was clear. There were small pigments on the corneal endothelium, which was present inferiorly. AC was formed centrally and peripherally had a Von Erich's grade 1, and there was no cells of flare. Iris.
So, Netra, before you finish, cornea has some more details which you normally examine. So what are the details normally that you will say?
Size, shape, luster, and transparency.
Okay, so what is luster?
The
shine, no? The shine that gets reflected. Yeah.
Luster.
So which condition is it affected?
Epithelial defects. Epithelial defects. Corneal edema.
It's yes, Lisa.
Sir, anything that is causing haziness in the cornea, like corneal edema.
It's lost in dry eyes. The luster is lost in dry eyes. You can have a corneal opacity, still have good luster. Okay, the shine comes from the lubrication, the tear film. So dry is you'll have loss of luster. Okay, so in a patient here, you're having a 3-year history of probably a uveitis, no, from the uveitis or chronic inflammation. What do you expect? What are the other changes that you can expect in cornea?
Direct the question to somebody.
Endothelial pigments will be there, sir.
Endothelial pigments can be seen in many conditions. Yes, it's already there in this patient also. So whenever there is a pigment release, you can have endothelial pigmentation. So there are many causes for endothelial pigmentation. Can you name a few of the causes for endothelial pigmentation?
So, angle closure glaucoma, pigmentous pressure,
Okay. Yes.
and uveitis,
Yes.
pseudo exfoliation.
Very good.
Fuchs heterochrome.
Yeah. Yeah. Looks endothelial dystrophy. Yes. Yeah.
Okay, so how do you differentiate between pigments on the back of the endothelium versus fine keratic precipitates? Meera?
Sir, keratic precipitates would be a 3-dimensional. We'd be able to differentiate.
Yes. It will be jetting like into the anterior chamber, but it's a 3-dimensional on the back of the cornea. Then what else? What about the color?
The pigments will be keratic precipitate would be greasy white, yellowish greasy white appearance. In case of mutton fat keratic precipitates, it would be
No, mutton fat keratic precipitates, there is no problem in differentiating mutton fat keratic precipitates from
fine
pigments.
bits.
The basic problem is about fine keratic precipitates, right?
Yes, yes.
Yeah, Netra.
You can have a BSK and things like that also in chronic uveitis, banship keratopathy. So nothing of those sort is there, yeah, no? It's clear, there's no classification in it. And here there is no KPs, right? There is no KPs also. Okay. Okay. Next.
Yeah,
Yes, proceed.
let's continue.
Netra, one more thing. See, if it is, I think your description of cornea is incomplete. You have to tell the different layers, no? Like, especially in a patient who with a long-standing intraocular pressure, what do you expect in the corneal epithelium? We expect microcystic corneal edema. Was it present in this patient? With the picture, I'm seeing it in a mobile device, so I cannot comment. But quite often you will be able to appreciate the microcystic edema, which will be seen as BDUE. Then stromal edema, when if the patient is having multiple episodes of anterior uveitis, you can have some amount of stromal edema, and maybe there may be a scarring, especially when there is HSV keratitis and all that. Then in the endothelium, as it was discussed, the pigments obviously would be there. Then if you see old KPs, that would be seen. There will be crenated KPs, there will be pigment dispersion all over the cornea. And sometimes in acute uveitis, you see the pseudo-guttate appearance that if you do a specular reflection, you can see that it's not proper guttate. You can see that the endothelium has a peculiar sheet, which is called a pseudo-guttate appearance. So that would be present in a uveitis. And that would be quite helpful in differentiating it from a angle closure glaucoma. So I think these are some vital points which you have not made a mention of. So what do you say about the endothelium? Was it okay, or was it appearing normal to you?
Endothelium is
So how do you see the endothelium?
So in here your question, sir.
Clinically,
what-
how will you evaluate the endothelium of the cornea?
By making a slit.
What is that? What is that called? Technique called
Specular, sir.
specular what?
Specular illumination. Specular reflection.
Yeah, specular reflection.
Okay.
So
Can
you
one
can
of you
also
tell
talk
me
about. You
the,
can also assess the sensation of the corneas.
yeah,
So Netra, how do you do a specular reflection?
So the illuminating arm of the microscope is positioned so that the beam of light, when reflected from the corneal surface, will pass through the oculars of the microscope. So then the angle of incidence will be equal to the angle of reflection.
Okay. And practically, how will you see in a patient?
Medium to narrow beam of light, sir. It must be thicker than an optical section, and the angle between the light and the microscope arm should be around 45 degrees, and the magnification should be around 25 times more. And
Okay. So this tells you that I don't know whether you've done it before. See, basically, we have to get a bright reflection from the epithelium, first thing. Okay. And once you get the reflection, you shift your eye. I mean, it's a uniocular view that you look at the specular reflection. So actually, the American Academy and all, they describe the beam should be 0.1 into 0.1. But that is not mandatory. Even if it is larger, it's okay. You can see it. So once you get the epithelial reflection, there are two ways of doing it. You can just focus it, you can just tilt the joystick anteriorly and you can see the endothelium. Till you get a reflection, you have to be careful. Then you increase the magnification, then you can appreciate it. That is one way. Second way is once you get a bright reflection on the epithelium, then you can adjust on the tilting screw and move it towards the one direction. So at that direction, like it depends on where you're viewing it from, you can see the specular reflection. The first method I described is the one that is more popularly used and that is more useful practically. Okay. The important thing is you should get the bright epithelial reflection, then have a high magnification and shift the joystick slightly anteriorly, you will get a reflection from the endothelium, which is much, much less brighter than the epithelial reflection. So then you can see a pattern, somewhat a rough pattern you can see. All right.
The endothelial mosaic pattern we'll see. Okay. Then corneal sensation. So that will, then you can comment if there is any corneal vascularization. It's none. Okay. No anterior chamber.
Anterior chamber was formed centrally and peripherally had a von Herrich's grade 1. There was no AC cells or flare. Iris was of normal color. There was no loss of crypts or coloroids, and there was no heterochromia. There was iris configuration was flat iris configuration, and there was loss of pupillary rough all around except at 1 o'clock position, and the PI was patent at 11 o'clock position.
There was no iris nodules.
No, sir, no iris nodules.
There was shallow chamber in the periphery, but flat iris configuration. What do you infer from that? A shallow chamber in the periphery with a flat iris configuration. You mentioned a flat iris configuration, and it is shallow in the periphery. What are the possibilities?
Shallow on the periphery, uniform shallowing.
No, you said it's not uniform shallowing, no? So flat iris configuration with the shallow anterior chamber in the periphery. Yes, yes. Mira, Lisa.
It's that means that there are some synovial closure at that point, which is pulling the iris towards the cornea and closing the angle there. And since YAG-PI was also done in this patient, so that has.
So there is no pupillary block. There is no pupillary block mechanism,
is not
but there is a synochial, possibly a synochial angle closure glaucoma. Okay, synochial angle closure. Sorry, not glaucoma. Synochial angle closure with no pupillary block. If there is pupillary block, what would you see?
A convex iris configuration.
Yes, you will see a convex iris configuration, not a flat iris configuration. Possibly it is because of the PA. Yes, maybe it is the PA that is a reason. Where else, in which other condition, you can see something like this? You may see, not always. Other than synochial, where else do you get a peripheral shallowing? Have you heard of Platyvirus Syndrome or Platyvirus configuration? Lisa, can you tell me what is Platyvirus?
Yes, sir. That is basically because the ciliary body is inserted more anteriorly, causing a narrow angle, and the iris configuration will be a flat iris configuration.
Okay, and, so you have a very anteriorly placed ciliary body. So the peripheral iris has to insert over the ciliary body. So there is crowding in the periphery. So, but centrally it may not be affected at all. Periphery alone can be affected, unless there is, of course, a pupillary block mechanism along with it. So there is a pupillary block mechanism along with it, then you will obviously have a shallow anterior chamber and a convex iris configuration also. So generally, it is detected post PA when the angles are not open. That is when you suspect this. And then, what would be the general signs in Platyvirus? How is it different from synochial closure and primary angle closure?
Double hump signs, sir, that will be seen in the gonioscope. So basically, the first hump will be formed by the ciliary body protruding through the iris, and the second hump will be the iris lying over the lens.
That's good. Yeah, that's correct. So generally, if you are not able to see the angle after a PA is done, it indicates a synochial, right? Because there's no pupillary block, you're supposed to see the angle. Now, if you're not able to see, there are two possibilities. Either it is synochial or it is a Platyvirus. So when you indent with great difficulty, you may be able to open up the angle. Also, you'll see that middle part of the iris going backwards. So you get the double hump. The first hump, like Lisa said, could be because of the ciliary body, and the second hump is because of the shape of the lens, the convexity of the lens. Okay, so that is how we differentiate. But Neta, you were saying about uniform shallowing. Where do you say uniform shallowing? The central and the peripheral AC is shallow. Where do you see that?
Yes, sir.
In which condition do you see that?
Can you repeat the question, sir?
Where do you see a periphery and central shallowing? In which condition? Where do you see peripheral shallowing as well as central shallowing? Both chamber is shallow.
Push mechanism.
Yes, the push mechanism glaucoma. Can you give a few examples of such condition?
Push mechanism.
Sympathetic ophthalmia, UV diffusion syndrome.
So push mechanism glaucomas can be either with pupillary block or without pupillary block. So with pupillary block glaucoma can be because of intumescent lens, can be because of iris cutis block in case of aphakia. Then it can be with without pupillary block, it can be because of iris and ciliary body cysts. It can be because of aqueous misdirection syndrome. It can be because of post-scleral buckling surgery.
Push mechanism glaucoma is a separate entity, and pupillary block is a separate entity. The push mechanism is independent of the pupillary block. Okay. So something is pushing the lens iris diaphragm forward. So what all can push? Where all can you see this push mechanism?
Iris and ciliary body cysts, aqueous misdirection.
Aqueous misdirection syndrome. Yes, aqueous misdirection syndrome. What happens in aqueous misdirection syndrome? So can this patient be having aqueous misdirection syndrome? Or no, because you don't see a uniform shallowing. This is more of a flat chamber. Yeah, and periphery shallowing. Aqueous misdirection syndrome, something like a tocoramate induced sulfur drug reaction, ciliary suprachoroidal effusion. All these areas you can see a push mechanism development. Okay. All right.
The same type of eye, Like you can see that there is a complicated cataract here. In the sense, there is a lot of synecdoche and there's a cataract. And if you see that the peripheral anterior chamber is very deep, what would be your thought process about it? If the peripheral anterior chamber in such a anterior segment is very deep.
And center will be normal, sir. Center is
Yeah, center is
full
reasonably normal.
can be because of any pull mechanism glaucomas,
Mhm.
neovascular glaucomas, any contracture membranes.
Okay. Usually it is seen in like for example, this is a complicated cataract in an older person. Probably it is a retinal detachment with peripheral PVR, and the PVR contracts and pulls the peripheral anterior chamber behind. Or there is a cyclitic membrane in chronic uveitis or endophthalmitis or something like that. There is a cyclitic membrane which contracts, which causes a ciliary body detachment, and it can pull the peripheral iris backwards, which actually causes a peripheral deep anterior chamber. All right. So these are conditions where you can have a peripheral deep anterior chamber. One more thing I want to ask you, Netra. Like this is a case of uveitis in which you said that the flare is completely absent. Okay. How do you explain the absence of flare if this is the case of uveitis? Usually flare will be present, right?
Yes, sir, but the patient was already put on steroids. So even if there was flare before that, then over because the
So
patient was
topical
already...
steroids would reduce the flare.
Is flare indicative of activity?
No, sir.
Flare
No,
is
sir.
indicative as well. So what is the indication of activity in a uveitis?
Cells, presence of
Cells.
anterior chamber cells.
Cells. So what is flare indicative of?
Long-standing
Amrita?
What causes flare? Think what causes flare, and then we can answer that.
And it is when there are cells, the light scatters.
What cells are? It's not cells, no?
No, we are talking about flare.
Cells causes cells. This is flare.
Gargi, what causes flare? Blood aqueous barrier is broken down. So once a blood aqueous barrier is broken down in uveitis, flare will continue to persist. So if you tell me that there is complete absence of flare, I understand that the uveitis had not been a very chronic uveitis. It may have been a very short-term uveitis, which is not treated properly, and that is why probably these synecdoche came in. This is my impression. Maybe right, maybe wrong. I don't know. But if you say absence of flare, that is what would go through my mind. Now, the patient has 3 years of continuous redness, pain, watering, photophobia, you are telling. And if that was because of uveitis, then this patient should have had a 2+ flare. In such a patient in whom 3 years of history of redness is there, and if that were to be due to uveitis, then with no flare, it's not uveitis. Okay, so there is a bit of contradiction here, right? So I'm keeping it now with myself. Let us move forward to see why it is so. Okay, so can we go forward? Anything else, Anil or Rehana?
Proceed, Netra.
Okay, proceed.
Moving on to pupils. Pupils with 3 mm, irregular pupil with multiple posterior synecdoche causing a festoon pupil. Direct reflex was absent and concentric reflex was absent. Lens. On torchlight
Was the
examination.
patient atropinized? Was cycloplegics in the medication list?
No, sir.
When would festoon be seen?
Multiple posterior synecdoche.
But usually a fistula is seen when there is multiple posters in between areas, there is no signic case, and when the pupil is trying to be dilated. So some areas will dilate, some areas are not dilating. So then you get this fistula. So what about the pupillary reflexes?
Direct reflex was absent and consensual reflex was absent.
Okay, so what is that indicative of? What does it tell you when direct and consensual are absent? What does it indicative of?
Afferent and the afferent.
Oh, is that what it means?
As in,
Yes.
Sir, in this case, it is
Pupillary.
basically a mechanical block that is causing the pupils to not move, and that is why we are not getting the reflex. It's afferent and efferent, we cannot predict as of now. It's
So you can have a complete loss of direct and consensual, not in an afferent problem. Afferent means it should have, from the consensual, it should have happened. No? So it is not readily indicative of an afferent problem. Afferent may be there, but this is a afferent effect. Okay, so afferent here most probably a local cause, the complete loss of sphincter tone. So that would be, or maybe patient is on some psychological mydriatic drugs with this festoon pupil and all.
yes.
Yes, Nathara, proceed.
on examination of the lens, on torchlight examination, grayish-white opacity was seen with an iris shadow. On slit-lamp examination, with direct focal illumination of the lens, showed a grade 2 nuclear sclerosis with thick posterior subcapsular cataract.
Okay, so lens is having cataract. What is generally what do you see in uveitis, especially chronic uveitis? What type of change will you see in the lens?
Complicated cataract.
What is the sign? What do you see?
Yeah, what is
Polychromatic
the
luster, breadcrumb appearance.
Polychromatic luster. Okay, fine.
okay? Why is polychromatic luster there? Why is breadcrumb appearance there? Why does uveitis give a predilection to the posterior subcapsular region? These three questions, do you know? Lisa?
So because of
Lisa? Netra, tell.
so because polychromatic lusters because of branching opacities within the cortical substance of the lens.
Why is there a predilection to the posterior subcapsular region?
Why not anterior capsule or the nucleus? Why is it posterior subcapsular region?
We have anterior uveitis, which causes posterior subcapsular cataract. It should cause anterior subcapsular or anterior capsular cataract, right?
Or metabolism in the posterior capsular layer, and because of the micropores, easy deposition of the
Okay, higher metabolism of the posterior layers of the lens. Okay. Okay, let us move further.
Left eye examination, eyelids
So,
and eyelashes.
generally, in your anterior, when you examine before you go to the frontal, you also try to see the anterior one-third of vitreous. So here, can you comment upon the anterior one-third of vitreous?
Anterior one-third of vitreous was clear, sir.
Anterior one-third of vitreous was clear. It is not possible to examine anterior one-third of vitreous here, no? How is it
Sorry, you
possible?
can't examine anterior because you can't see beyond the, sorry, sir. Can't see
Why
beyond
can't
the
you see? Why can't you see the anterior one-third of vitreous?
cataract. So can't see beyond the
Pupils cannot be dilated. No, you need a dilated, well-dilated pupil to examine the anterior one-third of vitreous. And
Or
cataract
even
is
if it is
also
a
there.
pupil like this, it should be a clear lens at least. For you to cut through the lens and go behind that. Okay.
Okay. Left eye.
Was there a PA in the right eye?
Yes, the
Yes.
PA was there. Yes,
Okay.
sir.
Patent PA was already.
Okay, Netra, how did you find out that the PA was patent?
Retroillumination, sir.
So retroillumination showed that the PA was patent. Retroillumination was normal in this case.
This patient has cataract, no?
Yeah.
Was it possible to get a retroillumination?
Is it possible to get a retroillumination through the PI in this case?
In this case, it's a little hard to get
It's hard.
retroillumination.
Yeah. But what did you see to say this was patent PA?
Oops. Okay, so in this case, you cannot see through retroillumination. You have to do the surface examination and see whether through that, I mean, the defect is through and through, and probably see a lens through that or something like that. Okay, that is all what you can see.
What do you see normally? If you just do a torchlight examination on a patient who has a PA, what would you see on the iris?
Light passing through the
You can see light passing through. You see a black area
Yes,
in
there's
the
a
iris,
black
no? A
area in the iris.
small black area. It could be a mole or a hole. We don't know. But slit lamp examination, you can see the hole. So when torchlight examination, because you don't get that much of magnification, you don't able to say it. But in slit lamp examination, you can actually do a direct focal examination of that particular area and then try to see the hole. Sometimes you may be able to see the ciliary process also through the opening. Okay, you will see clear area around the ciliary process, or maybe you are seeing an area in between two ciliary processes. So you'll be able to see a ciliary process if it is slightly in the periphery, but if it is more towards the center or in the middle, then you may not be able to see the ciliary process. But you will see a hole there. Okay.
Okay, let's proceed further.
Left eye.
left eye, eyelids and eyelashes were normal. Conjunctiva showed no congestion, discharge, or chemosis. Cornea was clear, normal in size, shape, lustre, and transparency. There was no endothelial, there was no stromal edema. There was small pigments on the corneal endothelium, which was present inferiorly. On anterior chamber examination, anterior chamber was formed centrally, and there was a Von Herrick grade 0 peripherally. There was no cells or flare. Iris was of normal color. There was no heterochromia, no loss of crypts or coloroids. Loss of pupillary rough was present all around. PI was patent at 1 o'clock position. Iris showed a flat iris configuration with peripheral anterior synechia. And pupils with 3
From
mm.
anterior synechia, were you able to see directly on anterior segment examination? No, you saw that on for the test. So basically, kind of similar picture of the other eye. Okay. What about the pupil?
Pupils were 3 mm, irregular pupil, and direct reflex was sluggish and concentric reflex was absent.
Okay, now what does it tell you? So in the other eye, you had the loss of direct and concentric. Here you have a sluggishly reacting direct, but concentric absent. Now, what can you say for sure? Especially keeping in mind the vision of the other eye.
That
Right eye optic atrophy.
Yes. So that means we know for now that right eye optic atrophy is there. And left eye, since direct is sluggish, it could be a local cause or optic nerve also there may be atrophy. Okay, both possibilities are there. We're not really sure about the optic nerve function yet. There is some activity we know, it is still active, but it's not complete atrophy. Okay, proceed.
Lens on torchlight examination, grayish white opacity with iris shadow was seen. On slit-line examination with direct focal illumination, grade showed a grade 3 nucleus sclerosis with thick posterior subcapsular cataract.
Again, anterior one-third of vitreous was not visible.
Anterior one-third of vitreous could not be visible.
Okay.
Gonioscopy done with Goldman 2-mirror gonioscope. Both eyes had more than 300-degree peripheral anterior synechiae. There were multiple focal peripheral anterior synechiae present superiorly and diffuse pars in all the other quadrants in both the eyes.
So were you able to see the goniosynechias directly with gonioscope, or you had to do any extra maneuvers to see the synechias?
The anterior could be directly seen.
Okay. What if the patient had a pupillary block glaucoma, like a primary angular pressure glaucoma? Then how would the angle be different in such a case versus this kind of a full mechanism glaucoma?
The peripheral anterior synechiae in case of a primary angular pressure glaucoma would not be visible directly during gonioscopy because it will be hidden under that
You
convex.
mean in a straight gaze gonioscopy? You
In
mean
a straight
gaze gonioscopy? Okay.
straight gaze
Okay.
gonioscopy. Because it will be hidden under the convexity of the iris, and it needs indentation to see if it's a peripheral anterior synechiae.
What about
or
manipulation? What about manipulation? What does manipulation tell us? What is manipulation gonioscopy? When you first do a straight gaze gonioscopy and you don't see the angle structures because convexity, the next thing before you do the indentation is to do a manipulation. No? So what are we trying to see in a manipulation?
Whether it is a ITC or a peripheral anterior synechiae.
No, that is differentiated with the help of indentation gonioscopy. You intend to differentiate between ITC, iridotrabecular contact, and peripheral anterior synechiae. Manipulation is seen to see if there is actually iridotrabecular contact. If there is any, if the angles are open in the periphery, looking over the hill appearance, is it, are we able to see the results or not? Then you indent and see. But can you indent with a tumor or here? What is the generally what lens used for indentation gonioscopy?
Indentation can be.
Yeah, it's a 4-mirror lens that is used, no? Right. So how does 4-mirror indentation help in differentiating this ITC and peripheral anterior synechiae? Dr. Meera?
Cause deepening of the anterior chamber, causing opening areas.
What of the anterior chamber?
Pushes the aqueous to the side, causing opening of the anterior chamber, which opens areas of oppositional angle closure.
Okay, so basically when you are pushing the central of the cornea, you are raising the chamber pressure in the anterior chamber. So the anterior chamber pressure increases and that aqueous is displaced to the periphery, thereby pushing the iris backwards. So this movement backwards, if it opens up the angle, it is only ITC and there is no pass. If there is actual pass, then the iris won't move backwards and you won't be able to open up the angle. Okay, so if you are having a diffuse area of pass, a large area of pass, then you won't be able to see any of those angle structures. Something like even a Platyvirus Syndrome or a chronic push mechanism glaucoma from the crowd concept, diffuse pass, or even a neovascular glaucoma, all those things will produce a diffuse pass. Whereas in a primary angular glaucoma, you would see broad-based pass, focal pass. In between areas, it will open up. That area you will be able to see the trabecular mesh. You may be able to see hyperpigmentation there. Okay. So here you see about 270, 300 degrees of diffuse pass. Okay. not a very classical picture of a primary angular closure glaucoma, more of a secondary angular closure glaucoma. Okay. Next.
In distant direct ophthalmoscopy, right eye had no glow and the left eye had a dull glow. Fundus examination, there was no further view because of cataract in both eyes.
Manoj, I wanted to ask you, what would be the difference between a gonioscopy pass in a primary angle closure glaucoma versus secondary angle closure glaucoma? Can you just elaborate a little bit on that?
Yeah, like I said in this patient, the pass is uniform and it is diffuse. Whereas in PSLGs, the passes are either can be focal passes or they are broad-based passes, but it won't be like covering all sectors, right? Multiple sectors altogether. So such kind of appearance is more favoring a secondary angle closure glaucoma rather than a primary angle closure.
Okay.
And of course, if you're seeing the patient for the first time in primary angular glaucoma, like Netra already said, you will see a convex iris configuration and these passes are visible on presentation only. Here we are directly seeing the pass with a flat iris configuration. Yeah. But this could be also because of the PA. So the PA is also, there is no pupillary blocks. That is not a criteria here because it's not a primary case. Patient is not coming to us directly. Okay.
Continue, Netra. Yeah, this you said. Fundus examination could not be seen.
So what are you looking for in the B scan? So here I can see it is normal.
If there's any vitreous hemorrhage or if there's any tractional retinal.
Why did you want to see for vitreous hemorrhage? What did you have in mind?
So basically, we should see RCS opening.
Karki, it was not audible. Can you repeat the answer?
Basically, in B-scan, we should see RCS opening.
We don't use short forms like RCS at all. Retinal choroidal complex. Okay. Why should we look at retinal choroidal complex?
Sir, in BKs or in BKs, there will be RCS thickening will be more, sir.
Okay.
So posterior uveitis or pan uveitis may be a differential diagnosis here. A push mechanism glaucoma may be a differential diagnosis here. So you are interested in the RCS complex thickness here, right? Because that is part of your DDs. That is why you're looking for that. What about vitreous hemorrhage? Is it a part of your DD? Could there be any reason why you're looking for vitreous hemorrhage?
There's any retinal detachment, a long-standing retinal detachment or tears because of.
So what type of retinal detachment do you expect here in such a patient who has a secondary or a synovial angioclosure glaucoma? What type of RD can be there? Is it a RRD, TRD, serous RD?
Exudative artery detachment.
Yeah, either it is an inflammatory exudative RD or sometimes this could be a neovascular glaucoma, could be a synovial angioclosure. So you may get a tractional RD. Yeah. Okay. Vitreous echoes, you are looking for echoes because maybe a pan uveitis is a differential diagnosis. You should look for vitreous echoes, not hemorrhage.
Yeah. It should be vitritis that you're looking at, vitreous haze that you're looking at, not for vitreous hemorrhage. And then retinochoroidal thickening.
You can also look at the optic nerve head. Yeah, optic nerve head if it is cupped or not. So that is a little tricky. You may get false positive and negative results. But if you can actually focus through the optic nerve head, you can appreciate the coupling. If it is a large atrophied cavernous atrophy, sometimes you may be able to see. Okay. Just because it is not seen on the B scan doesn't mean it is normal of this also.
So can you summarize the case now and come to a proper diagnosis?
70-year-old homemaker presented to us with complaints of pain and redness for 3 years duration, loss of vision in the right eye for 2 years, and progressive decrease of vision in the left eye for 1 year. And she had an episode of increased pain with redness 1 year back, for which laser peripherotomy was done elsewhere. And she was started on anti-glaucoma medications and also on steroids. On examination, pigments are found in the endothelium. Pupils
Okay.
Pupils were the right eye direct reflex and consensual reflex was absent, and lens had grade 2 NS with the PSC, and left eye had pigments on the corneal endothelium and AC. So AC in the right eye was also shallow with flat iris configuration, and left eye was also shallow with flat iris configuration. And lens had grade 3 NS with PSC, and pupils were direct reflex was sluggish and consensual reflex was up.
Okay. What is your diagnosis?
So my probable diagnosis would be both eye secondary synovial angle closure, glaucoma following anterior uveitis sequelae, status post laser peripheral iridotomy, both eyes immature senile cataract, right eye absolute eye.
So why do you think laser peripheral iridotomy was done in this case? So here we are talking about more of a synovial angle closure, probably a pull mechanism. Why do you think that laser was done? How can you explain that procedure?
Because if it was a pupillary block glaucoma, then they could have done a.
So why would there be a pupillary block glaucoma in this particular case? We are talking about this case. Yes, Lisa, Meera, Amrita, Gargi.
The synovial causing a pupillary block.
Synovial, you mean posterior synovial or anterior synovial?
Posterior synovial.
Okay, so what do you call that? In uveitis, when you have posterior synovial 360 degrees, you need to have 360 degrees posterior synovial. You call it? Seclusio pupillae. Seclusio. Occlusio is when you have a membrane covering the occluding, like a fibrin membrane coming and covering the pupillary area. Then if you get to call it occlusio pupillae, otherwise you call it seclusio pupillae. In such a case also, laser peripheral iridotomy may be done as a fix for the pupillary block, not just for primary angle closure disease. When secondary angle closure with pupillary block also, you can use laser PI. Okay. So can it be a primary angle closure glaucoma? Can you explain these symptoms or these signs if the patient to start off with had a primary angle closure glaucoma? Is there any way to explain that?
Patient could have had a primary angle closure glaucoma and could have got a PI, following which there was increased inflammation and the patient did not use steroids. So because of the increased inflammation, there could have been a synovial formation causing
yeah, but that wouldn't explain the peripheral anterior synovial. The posterior synovial is explainable with this. Okay, inflammations. Yes.
Is not.
Sir, it's muted, sir. Gopal sir is muted.
Yeah, even the absence of flare may be explainable on the basis of such a situation, where it was a primary angle closure glaucoma to start up with, and a PI-induced inflammation which was not probably treated well, causing all the synovial, posterior synovial. That may have less flare as compared to a chronic uveitis.
Can any of the medicines the patient uses could have produced such a problem?
Brimonidine-induced uveitis causing
the delayed hypersensitivity reaction to brimonidine can also produce uveitis symptoms. And that could have also was put on some probably a primary angle closure glaucoma with brimonidine treated, later on developed uveitis. Even PGs can also sometimes produce uveitis. PG means prostaglandin loss, not brimonidine. This patient was on brimonidine, right? Or what else can produce this kind of a pass in a primary angle closure glaucoma? This I told you, this pass, it doesn't look like a PSCG pass. No? So how can you explain, is there a possible way to explain such a diffuse pass in a patient who had a primary angular glaucoma to start off with? Yes, Meera, Netra.
Was any dispersion?
Pardon me?
Pigment
Which one?
dispersion?
Pigment dispersion will not produce pass, no? Pigment dispersion is different.
It will just
This
block
is
the
pass,
chapter.
peripheral anti-synechials.
Yes, yes.
When a PI was performed in a
Yes, yes. How can I explain with the PA? After PA, what complication could have happened which produced such a diffuse pass? Not UV, it is something else.
The aqueous misdirection syndrome.
Yes, yes. You can have aqueous misdirection syndrome following PA, especially in angle closure glaucomas. And such a patient has not gone for a follow-up, then that push mechanism could have produced a diffuse pass like this, all sectors covering pass. And then automatically over time, maybe they would put on psychoplegics or something, and it got reverted, and it should have led to such a synechial sequelae. Okay. So we are not very sure about exactly what has happened. What is the chronological order in which things have happened? So anyway, right now your diagnosis is correct. You can say this is a secondary synechial angular glaucoma, but yeah, probably anterior uveitis, chronic or intermittent anterior uveitis, and the patient is post peripheral, which means there is no pupillary block mechanism currently. Okay, immature cataract, absolute glaucoma in the right eye. Okay, all fine.
Okay, very rapidly, can we talk about the treatment, Gargi? How do you treat this case? I think Netra is a little hypoglycemic.
Sir, can give sir.
Gargi, you're on.
Didn't hear.
Sir, we can give beta blocker.
That is a single line answer for a very complex scenario. The patient has come with pressures of about more than 40 in a single seeing eye. The patient has a single seeing eye with very high pressures with synechial angular closure and cataract. Now the question is, how will you manage? So management would require investigations and then planning management along with counseling the patient, explaining the prognosis. So it's not a one-line answer that you should give or one-word answer you should give for a question about management, especially such a very complex case.
Okay, Yash, can you try? Lisa wants to try. Lisa wants to try. Okay.
Yes,
okay, Lisa.
So when the first management would be to medically try to manage the IOP. So the first line drugs, we can try the beta blockers and the alpha agonists and carbonic anhydrase inhibitors. And then if the IOP is uncontrollable with the maximum drugs, then we can go ahead with trabeculectomy. And one is if the problem with it, the process of this trabeculectomy is the patient, not the process, the con is that the patient might not be able to get a subjectively happy because vision is not corrected in this trabeculectomy. And then another option is when there is a borderline IOP and with borderline IOP with maximum drug control, then we can
yes, so
go
we are
ahead
talking
with
about this particular case. We are talking about a high IOP in this particular patient.
And 300 degrees of pass, do you think that medical management will work at all? Is it possible for medical management to work? 300 degrees of pass, peripheral anterior synechial.
trabeculectomy will be required.
Okay, so patient has come to you with a complaint of decrease in vision. And how will you address that?
Then we can first go with the phacoemulsification and then followed by a staged trabeculectomy. So
the three options that you can give to the patient with the like you said, the pros and cons are: one is do a phacoemulsification alone, the phacotrabeculectomy as a combined procedure, or straight away trabeculectomy. Now, how will you choose? When will you choose each of this?
then we can go ahead with the phacoemulsification.
When will you choose each of this? Because the patient has come with a complaint of decrease in vision. And how will you address that? The patient will say, I don't know, sir, you tell. Then how will you choose for the patient? Definitely, you should discuss with the patient the pros and cons of each of this, but then how will you choose? General guidelines.
So the disadvantage of phacotrabeculectomy is that because there are two procedures done at the same time, there will be increased inflammation and iritis associated with the procedure, which can lead to a trabeculectomy failure.
Okay, Netra, I understand what you're saying. So these patients, you saw the pupils, it is so cynical and cyanotic, so meiotic. So you need a lot of pupillar manipulation, iris manipulation intraoperatively to address the cataract. So that would obviously induce more inflammation. So doing a trabeculectomy along with it, there is a higher risk of failure, especially uveitic eye trabeculectomy failure is high. Then you're combining with the cataract plus the manipulation that you require during surgery. So there are higher risk of failure with phacotrabeculectomy. But if it is successful, then we are actually getting IOP under control and giving a visual recovery to the patient. So patient and the doctor will be happy in such a case if we are getting both correct. But it is going to be a tough task. Okay, so what about doing a trab alone?
The trabeculectomy, the IOP will be controlled, but the patient will subjectively not be happy because there might not be any improvement in vision.
Yeah. So, anyways, you will get the IOP under control. The patient requires a second surgery, that is a cataract surgery, anyways. So, anyways. So you will require a cataract surgery over a period of time, no? Anyways, so that may cause the trap to fail again. So doing a phaco first has advantage of giving visual recovery and the option of doing a staged trabeculectomy in a pseudophakic eye without any inflammation. So all these choices can be discussed with the patient.
But
and even a tube is possible after doing a cataract surgery. So that option is also there. If the risk of failure is more in trabeculectomy, even tube in a pseudophakic eye is possible.
Sir, one more thing that we should be doing in this patient is that since there are no signs of inflammation at present, and the patient is on steroids, so we can gradually taper off the steroids also because inflammation is not there, and maybe the patient is also responding to the steroids that are going on.
No, actually, if you are planning a surgery, I think this patient should be on systemic steroids through the procedure, and maybe we need to taper them.
Preoperative.
Number two is, since this patient has got very significant peripheral anterior synecdoche and very high pressure, I don't think before phacoemulsification by medical management, the pressure can be brought down. So in a high pressure eye, Manoj, would it be comfortable doing a phacoemulsification? It will be a little different. It will be also fraught with a lot of problems. So phacoemulsification first or trabeculectomy first also has its own problems.
So even trabeculectomy also, you are causing a sudden decompression of the globe if pressures are very, very high. Just like phacoemulsification or trabeculectomy, when you punch, you are directly causing a decompression of the globe, which can lead to a lot of problems, especially when the IOP is very, very high, like in this patient. It's been high for a long time. So in such a situation, there is another option. If the IOPs are very high and you need to do an incisional surgery, be it cataract surgery or a trabeculectomy surgery. But before that, if you want to reduce the IOP a little bit, what is the option?
Microdiode pulse laser.
Pardon me?
Microdiode.
TPC diode laser.
You can do a micropulse diode laser cyclophotocoagulation. Yeah, that is an option. So reduce the pressure first and then do a. It may not bring down the pressure to normal range or what the range is required, but it may bring it to a safer range.
And intraoperatively, probably you should use the pinky, the mannitol, the glycerol, all those, aqueous suppressing. I mean, the osmotic protection of pressures. Okay. Anything else, Manoj? I think we are reaching 1 hour and 20 minutes.
Yeah. Anil sir or madam.
Okay, I think that it was a very useful session, and this will continue. So this is a first effort by the KSOS to bring in an ophthalmology classroom for the postgraduates. So I think over every 2 weeks, we will have one case discussed in detail. And next time, I think it is from Kottayam Medical College. If I'm
Yes,
not
sir.
mistaken.
On 23rd of March, it is from Kottayam Medical College. And Dr. Jisha will be doing it on third nerve palsy.
Third nerve palsy or
Neuro-ophthalmology,
okay.
she said, and I think it is third nerve palsy.
Okay. So thank you very much, Dr. Manoj, Dr.
Thank you,
Rahana,
sir.
for coordinating
Thanks
the
for the
whole
opportunity.
event.
Thank you, sir.
And
Thank you,
my
Mike.
dear postgraduates for braving this particular session. And I hope it was,
Shubhanetra.
yeah, Shubhanetra was drinking a lot of water. I think she was doing some water drinking test. Okay, so thank you very much, all of you. And I hope that this will bring in much better, it will bring in much more information over times to come. And this will stay in YouTube. I think you all enjoyed it. Thank you very much.
Thank you, sir. Thank you, everyone.
Thank you, sir.
Thank you.
Okay, I